Good morning, attendees of this first Melbourne Institute Virtual Colloquium. Today's colloquium is focused on insights about opioid overuse and the implications of the current economic conditions on overuse. We have created this series to help us better understand Australian economic and social policy through the lens of Melbourne Institute researchers. I am Abigail Payne, Director of the Melbourne Institute Applied Economic and Social Research and the Ronald Henderson Professor. Let me extend a warm welcome to each and every one of you. Let me also acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Please also join me in extending a special welcome to our deans and deputy deans, our advisory board members, and key members of the government and the policy communities. Before I introduce my colleague, Professor John Deneau, let me remind you of a few housekeeping matters for this colloquium. This is being recorded. We have asked John to deliver his insights and then address your questions and comments. He will be speaking for approximately 25 minutes. Following a couple of questions, we will ask our reactor, Mr. John Ryan, to comment and provide his insights. John Deneau is a professorial fellow with the Melbourne Institute. He received his PhD in Germany and moved to Australia in 2011. John studies a range of economic and social well-being issues. In addition to his work on opioid overdose, John's recent work includes understanding the importance of economic expectations for retirement decisions, financial well-being and saving, and the role of work experience in understanding the rural-urban wage differential. Let me also introduce John Ryan. John is the inaugural CEO of the Pennington Institute. John is active in promoting sensible approaches to drug use in the community. He is a member of the Victorian Government's Medically Supervised Injecting Room Review Panel. As you may know, there is a room located in North Richmond with a second room soon to be created near the Queen Victoria Market. John Ryan will provide his experience and insights to fuller inform our exploration of the research and analysis that will be presented by John Deneau.
Okay, so if people can see that, then I'll continue on. So it's great to be here today to talk about a project that I've been working on together with colleagues from the Center for Health Economics at Monash for the last 2 years. And it's about the economic conditions of opioid overdoses. And when I talk about economic conditions, I'm really talking about the important role of unemployment. So let me just see if I can, yeah, here we go. Okay, so it's changing slides fine. Okay, so opioid-related deaths is the topic here. And when I talk about opioids, what I'm really talking about are medically prescribed painkillers. And so you go to your doctor, you have pain issues, you go to your doctor prescribes you these painkillers. And typically in the last 20 years, the drug of choice in Australia has been oxycodone. But of course, we're also talking about illegal drug sources, and some of these can be, of course, heroin. And I guess the development all started around the year 2000 when the Australian Pharmaceutical Benefit Scheme moved from treating or using opioids just to basically treat palliative care patients and terminally ill patients and very severe cancer patients. And they've moved into this chronic non-cancer pain area. And that has seen a just dramatic increase in the number of prescriptions and the number of users. And now we've got something like 3 million opioid patients in Australia. And of course, this comes with a lot of downsides because these are very potent drugs, and these drugs are very easy to overdose on. And so every single day we're seeing 150 hospitalizations, lots of emergency department presentations, and at least 3 deaths every single day in Australia. Now, of course, this pales compared to what we see in the United States, where they've got, depending on the numbers, something like 70,000 each year are dying in the United States. That's more than the number of US service personnel that died in the 10-year Vietnam conflict every single year. Okay, and so this is clearly a massive issue. Now, if we look at Australia compared to what's going on in the United States, and then scale down for our population size, we're at about half that rate, but it's still 5 to 7 persons who are dying per 100,000 every single year. So it's a lot of people. We're talking about something like 1,500 people every single year that are dying, and that's a lot more than are dying due to traffic accidents. It's not just an Australian problem or an American problem. It's happening really all over the world. Particularly hard-hit countries are like Canada, Scotland, Sweden. And what we're talking about really is pharmaceutical opioids, opioids that you received from your doctor. So if we look at the development of poisoning deaths since the year 2000, in the left pane, what we can see is the number of all poisoning deaths in the last 15, 20 years. And what you can see is a dramatic increase over this time period, all, of course, sort of scaled for the number of deaths per 100,000, okay? So it's all sort of normalized. What we see is a dramatic increase, and what's really driving it is the accidental poisonings. In the right pane of the graphic, what you can see is not just the poisonings, but of the opioids that are leading to this poisoning, and it's clearly the opioids that are driving this result. The flat line at the bottom of both those graphs is the development of intentional suicides by poisoning or by opioid. What you can see is that these results are being driven by accidental opioid overdose. If we were to take the unemployment rate for prime-aged working people, males and females, and divide them up into low, medium, and high areas, what you can see is very much a flat development between the year 2000 and 2007. Then we see a dramatic increase in all regions, high, medium, and low unemployment regions. And then at the GFC, what we see is a slight flattening off, but then a continued increase in the high regions and the medium regions. And it's only in the low unemployment regions where there's a flattening out, but it doesn't decrease. So the research question that we have here is, how are worsening economic conditions like the unemployment rate contributing to opioid deaths? And this is a very important topic given our COVID-19 situation. So we're asking ourselves, why and to what extent should the economy matter in these opioid overdose deaths? And I mean, there's all kinds of papers to look at pharmaceutical supply side interventions and sort of changing the way that opioids are being distributed. But this is really looking at the demand side. And unfortunately, what we see is that the unemployment rate, or effectively the risk of job loss, it really generates a lot of stress for those people who are still working. Also, of course, for those who've become unemployed, but for the vast majority that are still working, they're under stress. They're stressed about their ability to meet their financial obligations. They're under stress about losing their connections with their jobs, and of course, the stigma associated with unemployment. And there's lots of well-documented evidence about the subjective well-being hits that people take when they become unemployed. And here's a paper, Kassenbrummer and Heisken-Denu, from about 10 years ago, where we look at people who have lost their jobs due to company closings, certainly no fault of their own, yet the impact on subjective well-being is dramatic. And these kinds of sort of subjective well-being impacts, of course, can lead to opioid use. And we see sort of two avenues for doing that. And one, it could be simply the fear of job loss alone, but it also could be that some people are working, they don't want to become unemployed, they injure themselves, they take these opioids to continue working, and they never really have enough time to recover, and then they overdo it, and then there's an overdose, and then we're in a real mess. So what do we know what's going on in the literature in this particular area? Well, there's a cornerstone paper here by Case and Deaton in 2015, which looks at the American phenomena of middle-aged white men dying in record numbers. And they call this the so-called deaths of despair. And they show this sort of these rising mortality rates in connection with increased unemployment, detachment from the labor market. And so what we can see is that, yes, there is a connection here with economic conditions. The literature shows very clearly that, at least in short-term economic downturns, that there is an increase in opioid use and substance use disorders, so like leading to overdose. And there's also additional evidence that shows about economic downturns leading to increased emergency room presentations, and also even longer term regional level economic conditions playing a role in determining opioid related mortality. So the empirical strategy that we're following in this analysis is that we're looking at SA4 region levels in Australia, and we're looking to explain the number of opioid deaths at the SA4 regional level in Australia over the last 20 years. And so what we're doing is we're regressing the number of opioid deaths on the lagged unemployment rate, and that's our key variable for this analysis, the lagged unemployment rate, some demographic indicators that control for the gender and age composition of each region, region fixed effects, time fixed effects, and regional time trends. And so we call this a causal effect because we're controlling for the fixed effects. We're controlling for effects that hit any particular region. We're controlling for effects that hit all regions in a particular year. We're controlling for the characteristics of the region if it's following a particular trend. We're controlling for that. So it has to be everything over and above that. And so for it not to be causal, it would have to be some sort of an effect that impacts on the unemployment rate and deaths, or is correlated with the unemployment rate and deaths, yet is somehow not taken into account by these other controls. So we do a number of robustness checks and stability checks, which I don't really have a lot of time to show you here, but you can trust us. We've done all those as well. So we're focusing on explaining the number of opioid deaths at the regional level. So it's really important to say something about the data that we're using. So all of the opioid death related information comes from the National Coronial Information System. This is the online database that the coroners use. The police use it as well. And of course, researchers like us. And this captures every single reportable death in all of Australia since 2002. So if people have died really for any reason, there's a research done into what was the cause of death, and what we'll be using this information is the cause of death as determined by the coroner. And so what's really important is that we'll be using these ICD-10 codes, the International Cause of Death codes, which will allow us to determine what someone actually died of. And it's not just simply whether they had particular drugs in their system, but whether it was actually a contributing cause of death. So we're looking at all deaths in Australia which involve poisoning of a psychoactive substance. And so we can really cut out the sort of the cases that really are not really related to the research question at hand. So we've got data on the deaths We know exactly the information. This is all sort of police-based, coroner-based information. We know a lot of information about the deceased, and we're using this information as well. So we know where that person lived, and we'll be able to match other macro-level information to these indicators. So let's have a look at the econometric analysis that we've done. So this basically summarizes all of these regressions that I just talked about. So each one of these rows is a separate regression. So we're regressing the opioid deaths by on the lagged unemployment rate. And so if we take the Australia overall, if we run that main regression, what we get is that an increase in the lagged unemployment rate, and that's lagged by 1 year. If we increase that unemployment rate by 1 percentage point, what we get is an increase in the number of opioid-related deaths by 0.138 per 100,000. So that's the starting point. So we can see that's a sort of a general number. Let's start breaking it down into intentional and accidental deaths. We can see in the next two lines the 0.04 and the 0.10. We can see the action is clearly in the accidental deaths. So if we increase the unemployment rate by 1 percentage point, accidental deaths increase substantially. If we break it down by males and females, what we can see is it's the males that are driving this result. 0.23. So that's clearly a very strong result. If we break it down by age, what we can see is that it's the age group 25 to 54, prime working people, and that's what's really causing the increase in the opioid-related deaths. 0.288, highly significant, economically significant as well. If we break it down into employed and not employed, we can see it's the employed people that are at the highest risk of this increase in unemployment. And we talked about those mechanisms of increased stress and also people who are working, burning their candle at two ends by still working, even though they may be injured and are treating their pain with these painkillers. If we take it a next step further and we look at the age and gender connection, we can see that here we've got 3 age groups: 15 to 24, 25 to 54, 55 and up, and we can see for males and for females, all of the action is about the male category, aged 25 to 54. So the lagged unemployment rate is increasing the number of opioid-related deaths for males 25 to 54 by a much, much higher proportion, almost 1/2 of one death per 100,000. That's a very large number. So depending on your definitions, it's between 3 and 5 on average for Australia. We can take it a next step further and see the extent to which the male age, the specific male age 25 to 54 unemployment rate has any sort of spillover effects on other gender age groups. And it really doesn't, except for one small exception of females age 55 and plus. But you can see all of the effect really is on focusing on the male unemployment rate 25 to 54, impacting on the deaths of this particular age group. We can break it down even further. We have, because this coroner's information is so good, we've got information on the occupation of the deceased. And so what we can do is we can look at the occupations. And so it's the male unemployment rate lagged by 1 year, 25 to 54, that's really impacting on blue-collar workers, typically low-skilled blue-collar workers, machinery operators, and laborers. That's where the effect is coming from. These are the people at most at risk. We can break it down also even further and have a look at the types of drugs that are being used. So you recall that we have the toxicology reports, And we know that drugs that played a contributing role from the ICD-10 codes about which particular drugs played a role in the death. And what we can see is that the male unemployment rate, 25 to 54, lagged by 1 year, increases the number of oxycodone-related deaths by 0.04, significant. Also, we've got heroin and morphine. And the reason why we could have combined the results here is that when users take heroin, it metabolizes in the system and actually transforms into morphine. And so depending on when the toxicology report was done, it can be either picked up as heroin or as morphine. But these are very, very strong results that are just for a specific drug. So you can see that like the unemployment rate is actually pinpointing particular drugs that are associated with the opioid related death. So as a summary, we can say that, you know, from the econometric analysis, we can say that a 1 point increase in the lagged unemployment rate increases the number of opioid deaths by 0.14 per 100,000 persons. And that's a 4.2% increase. We know that it's driven by prime-aged working males. We know that it's the prime-age working male unemployment rate that is driving that. Males, laborers, the not married, and oxycodone, the standard painkiller that's been used in the last 20 years, and also heroin and morphine are the relevant drugs involved. So that's all well and good, but what does that mean now for COVID-19? And we've seen really a number of important things. This paper is all about the increase in unemployment. And what we're seeing here in this COVID-19 scenario is a substantial increase in official unemployment and a dramatic increase in other forms of underemployment. So this clearly is going to have some implications for opioid deaths. And we've got about a 1 year lag time. So we can see the writing on the wall. All of the analysis points to a 1 year lag being the correct mechanism. We know what's going to happen in 1 year's time. So what we've seen is an increase in the unemployment prevalence. So all these people who are now currently on job seeker, and for sure we'll see an increase in unemployment duration. We don't know that yet, but that writing is clearly on the wall. We've seen a dramatic increase in underemployment. So all those people who are currently on JobKeeper are not officially registered as unemployed. But come September 27th, there's going to be a massive swapping of people who are previously officially employed but underemployed, switching over to full-blown official unemployment. So think about what's happening with the daycare subsidy that's going on in Australia right now, where people have free daycare. Come July 12th, that's going to be removed. So people who are unemployed and relying on those kinds of packages, they're going to be clearly out of pocket and unable to pay for those kinds of services. So we can see that there's going to be some dramatic effects, but over and above that, there are some medical level issues. So in this COVID-19 scenario, unfortunately, what's happening is also that there is a disruption of the opioid supply. And so medically, what you have to understand is that these opioids impact on the respiratory system. So opioid users already have a diminished lung capacity. So if you can think about all of the COVID-19 related issues of troubles breathing, that makes them even more susceptible to like a medical related deaths. So people who are already using opioids and require opioids on a daily basis, they may have disrupted supply. They may be very desperate to use other pharmaceuticals to replace that disrupted supply. They may even turn to street drugs to replace it. They may go into withdrawal because they can't get enough supply. That may be enough to even cause death in and of itself. They may go into withdrawal and actually increase their tolerance, and the next time that they use, then they immediately overdose. So there's a lot of issues that are attached to this right now. Let's have a look at some of the economic issues. What we've seen just in the last couple of months is a dramatic increase in the unemployment rate. So the peak unemployment rate in the GFC was 5.9%. We're already way over that. We're at 6.2. So if we looked at the number of employed people, we can see that it's fallen off a cliff. We've lost 600,000 people. And of course, the next quarter's results are going to be also dramatic. We've lost 600,000 people. Where have they gone? Well, it's only 105,000 that have actually entered into unemployment officially. 400,000 have left the labor market. So they're not doing particularly well either. The real kicker is, of course, the drop in hours worked, and it's a 9% point drop in the hours worked, all within one or two months. If you compared that to the drop in hours worked in the recession of the 80s and 90s, that's a 6% drop. We're way over that, all within 1 or 2 months. So, and there's more to come. So this really does matter. If we combine the unemployment rate and the drop in the hours worked, what we're looking at is a dramatic increase in the underutilization rate, and we're now at around 20%. At the peak of the GFC, that was at 13.5%. It matters. So what are the implications all in all? What we're looking at is a really marked increase in the number of people that are on official unemployment, a dramatic increase in the amount of underutilization as seen by hours worked. We're already at 20%. We're going to be expecting a lot more people to enter into the official unemployment rate. That's going to make people very, very nervous. We can see that males in the prime age working group, 25 to 54, are particularly at risk of opioid-related death, particularly blue and low-skilled blue-collar workers and low-skilled machine operators. What we can see is that if we're going to move from, say, about 5 percentage points of unemployment to 10 percentage points, and effectively, there are some estimates that say we're actually, our real unemployment rate is actually already over 10%. What we're looking at is an increase in opioid deaths of around 21%. So that effectively, that means if we're at a standard rate of about 5 opioid deaths per 100,000 people, that 21% increase really equates to an additional 1 death per 100,000. So going from 5 to 6. That's the scenario that we're living in right now. And of course, that's just the tip of the iceberg, because people who are dying, that's a very extreme health outcome. Think about all the emergency room visits. Think about all the healthcare costs that are involved. Thank you very much for participating today.
Great. Thank you, John. If you can stop sharing, John, that would be great. So now we have time for a couple questions before I turn to John Ryan. So please remember you can write your questions using the Q&A function at the bottom of your screen. So the first question is I think I may have missed this, and it seems like another attendee might have missed this. Can you explain briefly why you think that there is a link between the unemployment rate and opioid use?
That's right. So there are a number of channels, and the first channel is that as the unemployment rate increases, there is economic insecurity. So am I going to be losing my job tomorrow? I can see the unemployment rate is increasing. It's affecting more people. Maybe I might be affected. And the vast majority of people are still working. So these people are worried about losing their jobs. And we know that the impact of losing a job is actually very, very large and significantly negative for subjective well-being. And that may be enough to spur people to use opioids. Another thing is of course, that people who, you can think about sort of a large group of for instance, trades workers who basically have been, doing overtime shifts, have been working, on weekends, et cetera, and they've seen that as a part of their regular pay. With unemployment increasing, there's a lack of demand. They don't have those shifts. They could be really, really under pressure. They also could be injured and using opioids to continue working to make sure that they don't get unemployed, and that can bite them in the end.
Okay, so given the opioids are a prescription drug, what role do the doctors play in terms of prescribing or under or over prescribing these drugs?
Exactly. So the thing is that doctors play an immediately a crucial role in the supply of these opioids. So there's been a lot of reforms that have gone on in the past several years, looking at ways really to identify opioid use disorder, to make sure that that people get only the amount of opioids that they need for a particular time. Unfortunately, what happens is that these opioid drugs are very, very potent. And for some people, it could be only a matter of a couple of weeks, and they become physically addicted. And unfortunately, there is some variation there, and it's not their fault to become physically addicted in a very short period of time.
Okay, and in terms of, so I have a question from another participant. So can you explain why you are using lagged unemployment rates instead of current unemployment rates?
Right. So the thing is that, of course, this is not an instantaneous process. It's not like you receive a drug and then all of a sudden bad things start to happen. It takes some time. And so the lagged unemployment rate allows for a continued use of the drug, allows it to have sort of an effect over time. And that's typically what happens, is that people have fallen off a ladder, people have injured themselves on their job, they go to their doctor, they receive these drugs, and over time, they because of the sort of the tolerance building characteristic of these drugs, they build up a tolerance over time, they use more and more, they become, unfortunately, addicted. And then with some lag delay, there is unfortunately, the medical effect of overdose and potential death.
Okay, great. While John Ryan is going live, oh, you are live. Okay, so let me turn over to John Ryan, and then we will continue with more questions after John's reactions.
Okay.
So thank you, John.
Thank you very much, and thanks for the invitation to speak. It was a fascinating presentation, and I must admit it reminded me that I shouldn't have studied comparative sociology at university. I should have studied economics. The challenge, I think, from a policy perspective is enormous. We've had a harm minimisation strategy in Australia for the last, well, since the mid-80s, and it's basically framed as a kind of negative in relation to drugs. It doesn't give adequate attention to the positive contribution that drugs can make, and that applies particularly to the pharmaceutical class. And it's so true that we have had an increase in the prescribing of opioids. The ambition is that people shouldn't suffer unnecessary pain. Unfortunately, it has resulted in increased dependence on opioid pharmaceuticals, and it's also clearly increased Australia's overdose toll. Hankton Institute started doing a report we called Australia's Annual Overdose Report a few years ago, because in our view, getting policymakers' attention to the issue was very difficult because these deaths are happening in suburbia and particularly in regional rural areas, and they're very much sort of silent deaths. And so we thought, if you don't count it, it doesn't exist. We started counting it, and the numbers really are disturbing. We haven't gone to the extent of America, it's true, but we are definitely going in the wrong direction in significant ways, one of which would be an expectation that, for example, real-time prescription monitoring will solve the problem. We need a much more comprehensive approach than that. And part of the challenge with real-time prescription monitoring is what happens to those people who are picked up as doctor shoppers. And most people that overdose are not actually in the doctor shopping category, but for those that are, they are at real risk. We're not doing nearly enough in the community about understanding overdose risks. For patients who are on highly potent opioids, that's a real issue. For their family members not knowing the signs of an overdose, that's a real issue. But for people, you know, for example, who are unable to access medical care for their opioid addiction, it's a tragedy and a perversity that it's cheaper to be dependent on pharmaceutical drugs than it is to be on opioid substitution treatment under medical supervision. So people are paying $5 a day for dosing at the pharmacy for opioid substitution treatment. They can get those the same sort of opioid effect without the supervision much cheaper. So there's actually an incentive for people to be, a financial incentive for people to be undertaking higher risk. I think the other element of this in terms of predicting the future, it's very hard in the drug market. It changes very rapidly, but Pennington Institute surveyed a couple of hundred people that are using drugs at the moment. Some have reduced their use, some have increased, some have stabilised, but the sort of expectation that there will be significant changes in the supply of illicit drugs such as heroin and also the illicit trafficking of pharmaceutical drugs seems to be likely, and there's every chance, I think, of a decrease in heroin availability and quite potentially an increase in fentanyl. That's what happened in America when the opioid restrictions started to impact doctor prescribing. People then accessed highly potent fentanyl and overdoses continued to rise. It just was a different substance. We haven't seen fentanyl on that scale in Australia, but if the heroin importation becomes more difficult and they're much easier to produce and make a profit from fentanyl becomes more common, we really do have a significant problem on the horizon, as we do with methamphetamine ice. And so I think the challenge for policymakers is to actually consider this issue, continue with a harm minimisation perspective, but spend a lot more time on community empowerment in relation to these issues, community education and better access to drug treatment, because we have a huge pool of people in Australia who are at risk of overdose, at risk of dependence, at risk of very negative consequences, and we don't have the treatment or community education capacity anywhere near to scale. So I think the paper is absolutely fascinating and, to be honest, quite disturbing.
Great. Thank you, John. So we have time for a few more questions. A question that I think both Johns can answer is, John Danu, you separated deaths out as being unintentional versus intentional. So I'm wondering if you both have a perspective in terms of, you know, the importance of the unintentional deaths and how we define unintentional. So specifically, are we misclassifying unintentional deaths?
Yeah. So the thing is that we're using intentional and unintentional, that classification as determined by the coroner. And so the thing is, of course, each case is highly complex. I mean, if you're using this particular data, you can see all the particulars around which each individual death occurred. And so these are effectively as determined by the coroner. So we take these medical assessments of intentional and unintentional, and we use those classifications. And the thing is, I think only really a medical coroner can make these judgments. So we're using the richness of the coroner data and connecting it with the economic indicators.
Okay. And John Ryan, do you have a
No, I think that's absolutely correct. I think the frustration, but it's understandable, is the delay that thorough process of coroners creates in terms of the data.
Totally agree.
So, we've got a lag. The biggest lag is a data lag, I think, in terms of understanding what's going on. And I think one of the policy implications is to try and reduce the period of time between someone's death and its complete investigation finalisation.
So that really plays a very important role. So you saw that the analysis went up to 2016, and the problem is that cases can take 2 or 3 years even to complete. And so what we're looking at is a real-time database where the cases are at various levels of completion. Some are complete, some are still open. And what we do is we use only the completed cases where we know what the coroner has determined. But there's many open cases now that are even a year old or 2 years old. I mean, it's a great resource. They're obviously doing the best they can, but that's the state of the data availability at the moment.
Okay, great. A question for you, John. What role do you think programs like SafeScript in Victoria have played?
Which John are you referring to?
Sorry, John Ryan.
Okay.
So I think SafeScript is an interesting attempt to try and come to terms with this issue, but my concern is that we're not carefully enough evaluating the consequences of the implementation of SafeScript. It's started in Victoria as for the whole state earlier this year, and it's too early to say what impact it might have. But I think one problem is it's not being carefully researched in terms of the impact. So people will die unnecessarily, I fear, because we're not aware of the unintended consequences. And we already know from America that it has shifted people who are dependent into the illicit drug market, and that's where fentanyl has taken off in America, and my genuine fear is that might happen in Australia. And obviously methamphetamine ice is a cheap alternative to heroin if it's not available, and it's not available in many regional and rural areas, in which case we could see unintended consequences such as increasing methamphetamine. The real challenge is to improve access to proper treatment for people who are opioid dependent, and I think there's massive gaps in the treatment capacity in Australia.
Okay, great. So I'm going to squeeze in one last question, so I'm going to ask for very short answers. John Deneau, in your presentation, when you differentiated based on occupation, you pointed out the coefficients for machinists and laborers.
Yep.
And while it wasn't significant, I noticed that the coefficient for professional was just as high as machinists. So for both Johns, do you think that this is an issue that that runs across all occupations, or just to one set of occupations?
Well, I think all occupations are clearly at risk, and all that we're picking up is based on the data that we have. And so you're right. The reason why we lumped the machine operators and the laborers together was the size of the coefficients. And so what we thought was that the machine operators were imprecisely measured, but it's still a significant, from its size, an effect.
And I think it's true that there is overdoses right across the spectrum in the community, and sometimes the drug might change. So you'll probably find more cocaine overdoses in the most well-off, and more methamphetamine at the least well-off. Opioids probably more spread more evenly.
Okay, great. So I have many more questions, but unfortunately we have run out of time. So thank you both, John and John. I have to say this is my First
Pleasure.
time moderating a session where both speakers were named John. So unfortunately, we're out of time. To our participants, I hope you have enjoyed this colloquium, and I look forward to seeing you again at our next one, which is being held on June 26th. Professor Guillaume Kaub will be presenting on the topic of employment and income policies in a post-COVID-19 environment. So thank you all for attending, and I look forward to seeing you again next time.
Thank you.